I'm not allowed to call myself local here. I'd probably get beat up. I'm like the white guy from Canada. I was asked to talk about early onset scoliosis, and that's a huge, really complicated and interesting thing. So I'm just going to talk about a little part of it, which I think is underappreciated and really interesting. So the conservative management. No disclosures. I want to acknowledge the folks who really taught me a lot about cast treatment of EOS. Jacques Destu, who was one of my mentors in Salt Lake, and Mike Pond was the PA who bridged from Jacques' practice over to mine when Jacques retired. Mike's done about 1,500 Mehta casts at this point. He's just a tremendous resource and source of knowledge. These kids were in the same church, same neighborhood. They both had early onset scoliosis. I don't know if any of y'all have been to Utah, but it's an interesting place, and there's a lot of kids with some funky curves. So a brief plea, I guess, that I think from a research perspective, being precise is very helpful, and the C-EOS, or the classification of early onset scoliosis, can really help us communicate and get better information out there. I think the etiology is the key when you're looking at these kids, whether it be idiopathic, neuromuscular, syndromic, or congenital. The Cobb angle, a bigger Cobb angle is worse, more rapid annual progression is worse, we know these things, but trying to be precise as we're communicating with one another and doing research. When we're talking about casting, the distinction between idiopathic and non-idiopathic is really the key. And I'd like to remind you that idiopathic scoliosis really is a diagnosis of exclusion. Sometimes you might find that a child has a connective tissue disorder when you're just wondering why they're so doughy each time you're putting on a cast. Sometimes a trip to the geneticist can be very helpful and clarify things. So specifically talking about idiopathic EOS, how do we predict progression? It's important to remember that most of the time when you see a kid less than 1 year of age, their scoliosis is going to get better. This study from 1965 showed a 92% resolution rate. Most of these kids were less than a year of age at the time they presented. A follow-up study a couple of years later showed a 90% chance of curve regression in a child presenting less than a year. However, they don't all get better, and that's where I'd encourage you to be very vigilant in following these kids closely so you can identify the kid that does need active treatment. So Mehta's study in 1972 helps guide us in terms of determining whether a curve is going to be progressive or not. It's sort of a Pareto principle 80-20 rule. If the rib vertebral angle difference measured at the apical vertebra is 20 degrees or more, there's an 80% chance that that curve is going to get worse. Vice versa, if the RVAD is less than 20 degrees, there's an 80% chance it's going to get better. You will still be wrong 1 in 5 times though, so that's important to discuss with the families. The phase of the rib is an even better predictor of progression. If there's overlap of the rib head at the apical vertebrae, that's a phase 2 rib, and all of these were progressive in Mehta's work. So low risk of progression when you're seeing these kids, small Cobb angle less than 20, RVAD less than 20, phase 1 rib. The converse would be a high risk of progression, and I'd also add thoracolumbar curves, or the rare child with the double curve is highly likely to be progressive. So if you're still not sure whether to observe or to treat, I think it's important to phone a friend or post the case on one of the resources like DocMatter or through the CSSG when I was in Utah. Now the PSSG, we would post cases and get other people's thoughts. Because I don't want you to wait 6 months to try to figure it out like we often would for our older adolescent patients and just see them back. Growth is happening really quickly in these young kids, so if you're not sure what to do and you can't quite decide, see them back in 3 or 4 months, get another x-ray even though it is more radiation, just to try to guide your treatment. So conservative management or treatment is the foundation of taking care of these kids with early onset scoliosis. I truly believe this. I greatly enjoy putting in growing rods or magic rods, but I think this is the best work that we do in taking care of kids with EOS. We know that delay is our friend when we're taking care of kids with growth-friendly surgery. This has been proven in a number of studies. Bess's work showed higher complications in TGR with every younger year that the growing rods were put in rib-based distraction, much higher complication rates and reoperation rates when the devices were put in less than 3. There was a study a couple months ago in JPO showing a higher rate of uproar in kids who had rib-based distraction less than 3 years of age. However, sometimes early surgery really is your best choice. For example, for an isolated hemivertebra, when they're canted to the side, it's going to create a compensatory curve. I think pulling the trigger early is pretty effective. So once you've decided to treat this idiopathic child with EOS, you have 2 options really. It's a brace or a cast. Miss Mehta's study in 2005 really kicked off the renaissance of cast treatment in North America and elsewhere. She presented on 136 kids with an incredible nearly 11 years follow-up on average. There's problems with this study in terms of the phenotypic classification system used and in terms of the fact that a lot of these kids were casted very, very young and may have had a resolving kind of scoliosis. Nevertheless, 69% of these kids after cast treatment had a scoliosis less than 10 degrees, and that's sort of a spread from when she published this study. The reason I cast is really clear as opposed to using a brace. There's much, much better results, particularly for our idiopathic population. Some of the advantages of casting are greater forces are applied, there's better molding, better correction. Not better compliance, there's guaranteed compliance, which is I think the biggest factor. Because I mean, my daughter has scoliosis, she's almost 13. She wears her brace, she does really, really well because, you know, I'm forcing her to do it, and that's not the case for all of our families. And so when you're talking about a limited window to effectively treat these kids with a cast or a brace, I think that a cast guarantees compliance. The disadvantage, the one that's often quoted and is very, very real, is that a general anesthetic is, I believe, required in order to put on a really good cast. Some people are doing this awake. There was a PSSG study from last year showing equivalent results between the awake casting and the asleep casting, but their published results, at least in that study, weren't as good as some of the other ones I've seen. I think if you want to do a really good cast, at present you are not obligated, but I would encourage you to do it under a general anesthetic. However, we do have a girl that we're casting here in Hawaii right now. We're doing her awake. She's a family of, she's like the 9th child, this really chill family off the North Shore, and this girl just falls asleep while we're putting on the casting clinic, and it's great. She's got congenital scoliosis. We are trying to buy a couple of years to keep her curve from getting worse, so I think it's not unreasonable. So if I feel that treatment is warranted, I really recommend cast treatment as opposed to bracing. The youngest kid I've casted was 10 months. The youngest child Dr. Destu casted was 9 months. I think when the kids are smaller, you have to think carefully about whether or not they're robust enough for the casting process if you're putting on a real tight cast. Other folks have described casting kids as young as 6 months though. So here's a case from Dr. Destu's practice. This was an 8-month-old female. She had a column angle of 52 degrees, RVAD, highly suggestive of progression, as well as a phase 2 rib. 11 months of age in her first cast, noted to be really flexible. She had 6 casts over just over a year. She's got a 12-degree curve at just over 2 years of age, and she was subsequently braced for a year. And seen at final follow-up at the age of 10 with a little bit of spinal asymmetry, but she looks pretty good. And they obviously don't all go like that, but that's sort of the poster child for what we're hoping for. So there is one study out there on bracing at present, and I think it's pretty reasonable, and I'm very thankful for Dr. Tomitz for putting this out there, because a lot of folks talk about bracing as an alternative to casting and treatment of EOS. He had 9 kids with a mean curve of 45 degrees. They applied Mehta-style forces and then had a CAD-CAM brace that was fabricated. 44% of the kids had a quote-unquote cure, and we always put cure in quotations when we're talking about EOS because we just don't have long-term follow-up at this point in time. Pretty good results. This is a really young cohort with somewhat smaller curves. In the body of the article are my concerns with it. Among the 9 patients, each one had on average 2 casts applied before bracing, and the braces were all molded under general anesthesia. So some of our concerns about casting, the GA, are still there with this. So we have a young cohort. The results aren't as good as what we see with casting at shorter follow-up, and they still need a GA. So I think that there's some potential here, but at present I think that casting has better results. So what I want to convince you of today is that if you have a child with early onset scoliosis and it's idiopathic, that you should try to start casting as soon as you are relatively confident that that curve is going to get worse. Because there really is a window when casting can be much more effective, and you get to a certain age and the results drop off dramatically. So this is the only other intermediate term follow-up besides Ms. Mehta's study. These are Dr. Destu's patients. We published on this a couple years ago. We found that at an average of 8 years after the beginning of treatment, these kids had about a 49% quote-unquote cure rate, getting the scoliosis down to 15 degrees or less. We use that to fit in with some previous studies. So those are pretty good results. 73% of the kids, however, at final follow-up had at least a 20-degree improvement in their curve. So if you have a kid that starts out, they're 2 years of age, they have a 50-degree scoliosis, now they're 10 and you've gotten them down to a 30-degree curve, I think that's a huge win. That's a kid that you're continuing to brace and hopefully even avoid surgery altogether. We followed this up with a multi-center Shriners study when I was in Salt Lake still, looking at 5 hospitals. The majority of these kids came from Salt Lake, about 140 of them, Greenville and Chicago. This was over 17 years, a minimum of 2 years of follow-up after the end of casting, which is, I think, an important distinction. We had 331 patients who were casted during the study period, various exclusions, including inadequate follow-up, and then a big chunk of them that were non-idiopathic, which we'll talk about really briefly. So we had 138 kids with idiopathic early-onset scoliosis. It's the largest cohort so far, and now that I'm no longer in academics, I have to muster the energy to not go to the beach and write this up and try to get it published. But the bulk of these kids were less than 2 years of age at the initiation of casting. We had an average of 5 years of follow-up after cast treatment. Initial scoliosis of 51 degrees, and this slide is really just second from the bottom to show you that the initial scoliosis wasn't significantly different between these groups. There was a bit of a trend, but by and large, these kids had real scoliosis that was progressive, and these weren't very, very small curves that were going to get better on their own. So if you remember one slide, this is the one that I'm hoping you'll remember. Of the 60 kids who started casting at younger than 18 months of age, 72% of them at final follow-up had a curvature of less than 15 degrees. It's really, really good, 70%. This is the only study that really approaches Ms. Mehta's results, and I think the key is really starting the casting very, very young. This is growth modulation. It's not like a clubfoot in the sense that we're lengthening out the tendons. We are applying asymmetric forces to the spine. We are trying to modify Hutter-Volkmann principle, as Dr. Samdani was alluding to yesterday. We're trying to modify the growth on the concavity and get it to catch up. So when you start young, when they're growing really, really fast, we have tremendous results. 84% of the kids at final follow-up were at least 20 degrees better. Surprisingly, as soon as you look at these kids from 18 to 24 months of age, the results fell off really, really quickly. And this was a surprise to me. I'd submitted the abstract looking at just 2 years and under, and then we decided to kind of analyze it some more. When you're looking at the 18 to 24-month-old group, only 36% of the kids were quote-unquote cured at final follow-up, and only 57% of them had improved at least 20 degrees. There's a big drop-off in your results with casting if you wait a little bit longer. The results in the 2 to 3-year-old group were very, very similar to that 18 to 24-month-old group. And then we get into the older groups, 3 to 4 years of age at the start of casting. Note, 5 Shriners hospitals over 17 years, only 13 kids fit into this category. Whenever anyone tells you they know what happens for these older kids with casting, grain of salt, they've probably treated a couple. What we see is that only 23% of the kids had a quote-unquote cure. Only about 30% of them were improved 20 degrees. However, it's really, really hard to predict which of those kids is going to have a response to casting. There was one child who was older than 4 at the start of casting. He was 6. He had a 60-degree curve in Salt Lake, and somewhat miraculously, he was cured. But the majority of the time, these older kids with idiopathic scoliosis, casting has limited efficacy. And it's not to say that you might not hold the fort just as effectively with a cast as with a brace, but a lot of the time in these older kids, I would try a brace first. And if you're losing, maybe try to make up a little bit of ground with a cast, but I think once you get to 4, it's a hard sell to consider casting. So metacasting, EDF casting is most effective in young children with small scoliosis. 70% success-ish in a child who's less than 18 months of age. It's really, really important, I think, and the success falls off pretty dramatically. But which child responds to cast treatment can be really surprising, and it's important to give them a chance. So really briefly, I'm going to whip through some of the hows. This is how we do it in Canada still. It's pretty effective. I think Risser casting at this point in time really is of historical interest. There's not published literature documenting good results. Alternatively, repetitive cast brace treatment, again, it's published, it's an option. The results aren't as good as what's been documented for Mehta casting, which is the eponym associated with EDF, or elongation, derotation, flexion casting. So the elongation stands for, elongation. Longitudinal force applied through a pelvic girdle and head halter traction. You're going to transversely derotate them through the apex of their curvature and then laterally flex them to deal with the coronal plane deformity. Plaster cast for a good mold, overwrapped with fiberglass. The technique was developed by Drs. Cottrell and Morel in the 1960s and then subsequently adopted by Mehta and others. It's really important to have your anesthesiology team on side for this because we are iatrogenically inducing restrictive lung disease while we're doing this, and sometimes you got to hustle to cut out the belly hole if you're putting on a good effective cast. So I would say in Salt Lake we did about 80 casts a year, and probably 1 in 10 kids would get canceled either by our anesthesiologists in the pre-op area or before we even started putting plaster on because they weren't ventilating really well, and they had that experience to know this isn't going to go well, let's not push our luck, let's wait a couple weeks. So Team effort, really, really important. There are no commercially available cast tables, to my knowledge, at present. At the Shriners Hospital here, when I was there previously, we had a version of this cast table, which you can't get anymore, and there was another one, which apparently you can't get anymore. So there's a niche, but you can also make your own. I love MacGyver when I was a kid, and there's lots of ways to sort of make your own cast table, and some published examples of how to do that. Here's some of the things you'll need. Happy to provide a list to folks who are interested. Here's some of the things we do, but more quickly, we'll just kind of whip through it. Protect the eyes, protect the ears, bite block for the head halter traction to keep their tongue, and decompress the stomach, because that's going to give the lungs a little bit more space, so you have a little bit more space to push when you're molding your cast. So pelvic traction, basically whatever their weight is in kilos, I just use the same in pounds, and I get a little bit leery once you get above 13 or 14 pounds because you're pulling on little necks, and it's probably not that necessary. This isn't slowly applied halo gravity traction a couple pounds a day. You got to be careful. Head halter traction on. We've got asymmetric arm abduction to promote that lateral flexion and remind you to make asymmetric cutouts for your cast. Some extra padding, web rail, plaster. Everybody's getting ready. And this is a 3-person job when you're putting the casts on. The surgeon is anteriorly derotating over the convexity of the curvature and then laterally flexing through the other axilla. You have one person at the top who is providing derotation on the anterior shoulder and then smoothing the cast on the back, and somebody manning the pelvis. And you gotta hustle, you mold the cast, and then at that point in time, you gotta get the fiberglass on and then get those cutouts. If you're not, every once in a while, I think, dancing a little bit on that CO2, getting a little bit high, you might not be putting on a tight enough cast. So this is the technique to anteriorly derotate things. Here's the finished product. A wet A-strap to promote lamination between the layers. You make your cutouts. Staple gun is key, makes it much, much quicker. Flip them on a couple of transverse bolsters in your posterior window to allow the spine to derotate to go where you want it to go, and then finish off on the front. So this is what most of the casts look like at the end. We did a study in 2018 comparing the results at the Greenville Shrine to those in Salt Lake City and found no difference. And Dr. Stasikelis in Greenville never put shoulder straps on. Miss Mehta told him that his casts were going to fall off, and that never happened. Here's an example of Dr. Destu's cast in the top left, Stasikelis in the middle, and sort of what we adopted in Salt Lake City, sort of a hybrid. The best cast would have asymmetric rib flanges, but people don't like how that looks. That would be the best cast, though, to promote that rotation. Frequency of cast changes is really taken from Mehta, and it seems to work when they're 2 every 2 months, if they're 3 every 3 months, if they're 4 every 4 months. Some of the non-idiopathic kids grow really slowly, and you can do a less frequent cast change, and that seems to be okay. Anecdote really guides when to stop. What I moved towards was getting an upright x-ray rather, out of cast every 6 months. They could be out of the cast for a couple of days. This is guided growth. We're trying to change that trapezoidally shaped vertebral bodies at the apex. When they're 10 degrees or less, you'd mold for a brace during the next cast application. Lots of variables here, and I don't think anybody really knows. Here's an example of an EDF style brace, which we would mold for the younger kids in the hospital, oftentimes awake. What do you do if you're not going to win, if you're not going to make their scoliosis go away? I really don't think anybody knows. Around the age of 4, because we know that there's so much less growth and potential for further correction, I often consider changing to a brace for a trial around that point of time. We showed in one study that when you brace for a little while, you can usually get back to where you were within a couple of casts. So once you have an older kid, you're not going to get a much further correction. Try a brace for 6 months. If you lose 10 degrees, family's upset, go back to casting and you're probably going to be okay. I think it's really, really tough to send kids to school with a cast on, but lots of folks do. I strongly urge families to give it a year to get a sense of change. This is guided growth. It takes some time. And I assess it in 6-month chunks, not with an x-ray after every cast, because that just creates anxiety. I probably looked at 1,000 in-cast x-rays for some of our original studies, and some would be better and some would be worse, and it was not linear by any means, and that just creates a lot of anxiety for the families. So look at it every 6 months or so, set their expectations appropriately. We showed that cast holidays within the first year are going to have a higher cob angle, and they're going to be less likely to have a cure And so actually 18 months, we really try to dissuade people from a cast holiday. The kids who are successfully casted, on average, it's going to be about 6 casts. It's going to take you somewhere between 12 to 18 months. That's sort of the sweet spot. Every once in a while, a kid will have a really, really rapid response, and it's great. If you're up around 8, 9 casts, you're probably not going to quote unquote win. What about non-idiopathic kids? Josh Page looked at our data and presented this. Really unlikely that you're going to win in the non-idiopathic kids, regardless of the etiology. At a win in a Marfan's kid and in one kid with Prader-Willi syndrome, but it's very, very uncommon. Only 15% at final follow-up had improved at least 20 degrees. However, the delay has a lot of value. So in that cohort, the average age for growth-friendly surgery was 7.5 years, which is a lot better than putting in growing rods or magic rods when they're 3 or 4. I still think that groups like the PSSG with their huge numbers can do some really good work to better delineate which specific non-idiopathic etiologies are best suited for casting, but it's an option and you can buy some time. So casting can resolve scoliosis in somewhere between 30 and 70% of kids with idiopathic EOS and a much smaller proportion of the non-idiopathic kids. Start treatment early. Less than 18 months has dramatically better results than the older kids, and in most cases it can at very least delay the need for surgery. Don't wait. Growth is the corrective force in the conservative treatment of EOS, and we have an ICL in a month in San Diego if anybody wants to listen to 2 hours of EOS stuff. So, but don't worry, I'm not talking the whole time, so it's way better. Thank you.